Okay, so now let's talk about one of the lesions, one of the SOLs, space occupying lesions, one of the tumors that are quite very known and very discussed in otolaryngology, which is the vestibular schwannoma. A lot of times this schwannoma is getting into the differential diagnosis of hearing loss, especially sensory neural hearing loss and tinnitus, especially unilateral tinnitus. So this is a tumor of the Schwann cells. Let's call it Schwann cells tumor. Just for reminder, the Schwann cells are the cells that compose the axon of the neuron. If there is a neuron, it has its axon, and the axon the axon has the nodes on Ranvier, nodes of Ranvier. Here the action potential propagate between one node to the other and getting into the end of the axon in the synapse, and between these nodes there is the Schwann cells, which are used as isolation so the electrical potential can propagate rapidly throughout the axon. Those are the Schwann cells in the central nervous system, the oligodendrocyte doing the function of the cells, but in the periphery and on the 8th cranial nerve there are Schwann cells. So the lesion, this tumor of Schwann cells from the 8th cranial nerve, is called the vestibular schwannoma. It's the cerebral pontine angle tumor. Usually the main tumor that I talked about in the cerebral pontine angle between the cerebellum. If you think about the brain, I don't know, think about the brain for a sec. Okay, so you have here the cerebellum. This is the cerebellum, and here you have the pontine and the midbrain, pontine and medulla. So here in the cerebral pontine angle, the tumor can arise, and maybe in the axial position it's here, and the tumor arise, and it can push and compress the 8th cranial nerve and therefore cause the symptoms of vestibular schwannoma, which are sensory neural hearing loss, especially in high frequencies, tinnitus. And now usually the vestibular schwannoma is unilateral except for neurofibromatosis type 2. Here we have bilateral, but usually for ordinary patients, usually it's unilateral. Therefore the tinnitus and the hearing loss are also unilateral. So there is sensory neural hearing loss and tinnitus, which is usually unilateral. The tinnitus is usually subjective and not objective. Namely, it's not a pulsatile tinnitus, it's a tinnitus that is subjective. And there can also be other symptoms, for example vertigo and disequilibration and things like this, if there is also compression of the vestibular part of the cranial nerve. But the most common presentation is the sensory neural hearing loss in the high frequencies, usually with tinnitus. Now it can also present as sudden sensory neural hearing loss. Now for diagnosis, we start with an audiogram. Here we see, as you can expect, sensory neural hearing loss, high frequency. Usually you should suspect it when there are at least 15 decibels difference between the health ear in two consecutive frequencies. Namely, you can see one audiogram that look like this and another audiogram that look like this. I don't know, maybe this one. Okay, and here there is at least 15 decibels, and this is the frequency, and this is the threshold. So there are, let's say that this is the right ear, this is the left ear, so there is at least two frequencies with at least 50%, 15 decibel difference. It is suspicious for vestibular schwannoma in this ear. Usually there is also acoustic decay in the acoustic reflex test. Now, acoustic decay is the phenomena in which the patient acoustic reflex decay as the sound as the time elapses with the high sound. Let's start with it, that the acoustic reflex is a reflex that should protect our ear from high decibel sound. So it contracts the subedius muscle and the stapes muscle to contract the ossicular chain and protect the ear from high sounds, high decibels, from acoustic trauma. So the acoustic reflex is when we hear a very loud noise, those muscles contract and make the tympanic membrane more stiff and less, transmitting the sound to the inner ear, to the cochlea, and making acoustic trauma. But when there is vestibular schwannoma, there is acoustic decay, namely that if the sound continues, for example, for more than, I don't know, 10 seconds or something, the acoustic reflex starts to decay and the muscle starts to not contract and the reflex decay. This is characteristic of what is called retrocochlear pathology, of which the lesion is behind the cochlea. The cochlea is here, it's behind the cochlea to the direction of the brain. So it's a retrocochlear pathology, like acoustic schwannoma, have the characteristics of acoustic decay. Another very important and very unique presentation of retrocochlear pathologies, like vestibular schwannoma, is the discrimination, let's say reduction, or speech discrimination. So there is a test in the SRT. When you check the SRT, you check if there is speech discrimination, and what you see in acoustic schwannoma, you see that there is a very high reduction in speech discrimination with acoustic schwannoma. Namely, you see a hearing loss, but its speech discrimination is very bad, below 80%. Now there is also a phenomena which is called the rollover phenomena. In this phenomena, as you increase the sound, you expect that the discrimination will also be better, but no, you increase the sound but the speed discrimination decrease even though you increase the sound. This is something that is characteristic of retrocochlear pathologies like vestibular schwannoma. So we have this tumor in the cerebropontine angle from Schwann cells, which is called vestibular schwannoma. It causes compression of the 8th cranial nerve with hearing loss in the high frequency, tinnitus. It can also cause vertigo with at least usually 15 decibel difference in two consecutive frequencies between the ears, with acoustic decay and with this speech discrimination that is worse than what you would expect. This tumor can be recognized using MRI with gadolinium in the cerebropontine angle. There, after we identify it, it can be treated, Now, what is the treatment that is needed? It depends. If it is small and asymptomatic, sometimes it is just observed and not treated. And if it's symptomatic and compress the 8th cranial nerve, it can be treated. Now, there are some treatments. One can be stereotactic surgery. Now, stereotactic surgery is usually reserved for patients with small lesion, or older patients, or those with comorbidities that cannot undergo the surgical treatment. The other option, which is the microsurgery, is for patients with bigger lesion that can undergo a surgery. And in this surgery there are let's say mainly two types. One type of the surgery is the hearing conservative surgery, and the other type is for those without hearing to preserve, so non-hearing preserving. It changes on how the tumor is approached. Hearing preservation approach is from the middle cranial fossa or retrosigmoid approach, and the non-hearing preserving in this translabyrinth approach. So the approach is different. Another thing that I should have mentioned is the ABR test, which is the auditory brainstem response testing. Auditory brainstem response, which usually show pathologies in the it has waves. So in the 5th wave in the ABR test, there are pathologies like increased latency or absence of the 5th wave in auditory brainstem response. This is another test that can be used to identify. But when you're doing an MRI with gadolinium, you should see the tumor, and this is maybe the best way. So if there is any patient that come with 15 decibels at least of difference between the ears in 2 consecutive frequencies, it is suspicious for vestibular schwannoma, especially if it has acoustic decay. The tympanometry is going to be normal. The audiometry should be sensory neural hearing loss, namely high frequencies usually, without airborne conduction, airborne gap, because it's not a conductive hearing loss, it's a sensory neural hearing loss. Acoustic decay we said, ABR we said, MRI as we said, and remember that it is also a lesion in the brain, a tumor in the brain, so also it can cause compressions. I said compression of the 8th cranial nerve, but don't forget compression of the brain and neurological symptoms, so look for neurological symptoms as well. But this is it generally about, and the script discrimination is very important because it's very characteristic of retrocochlear pathology behind the cochlea, which vestibular schwannoma is one of the important retrocochlear pathology, but not only one. For example, multiple sclerosis can also be a retrocochlear pathology, or brainstem lesions that are others, tumors. Okay, so this is some words about the vestibular schwannoma, acoustic neurinoma, 8th cranial nerve tumor. I don't know, call it as you like, just know that this is the vestibular schwannoma. In one genetic disorder, which is the neurofibromatosis type 2, it can be bilateral, but usually unilateral. Bilateral acoustic schwannoma is very characteristic of neurofibromatosis type 2, so it's usually genetic. But usually vestibular schwannoma is unilateral with hearing loss, sensory neural hearing loss, and tinnitus. Thank you very much. If there are any mistakes or correction about vestibular schwannoma, please tell me. It was based on the MEC manual, what it is written there, but maybe I made mistakes. Thank you very much, and this is it.